Hello everyone. So we perform echo frequently on our ED patients to assess cardiac contractility, which we can do either by measurements or by visual estimation. Most of the time we do it by visual estimation as it's a very rapid method. Therefore, we need to train ourselves in this skill so that the interpretation that we make is accurate and reliable. So here I'm putting together the techniques or approaches for assessing cardiac contractility by visual estimation. There are essentially four things that we look at: muscle thickening and shortening, mitral valve anterior leaflet excursion, axial contraction, and longitudinal contraction. And then we will categorize the contractility into one of the 5 categories of EF, from hyperdynamic to severely reduced. My strategy in this tutorial video is to concentrate on the normal EF first and compare it with the two ends of the spectrum, i.e. hyperdynamic and severely reduced EF. We will leave out the mildly reduced and moderately reduced EF first at the beginning. The intention is for us to train our eyes repeatedly with what normal looks like, and then what the two ends of the spectrum look like compared to normal. So then later in the tutorial, hopefully we can then recognize the other EF categories that fall between normal and severely reduced EF when we see them. So let's begin with first looking at muscle thickening and shortening. In echo, a lot of structures are in motion. This can easily be perceived as contraction. What we need to look for is whether the myocardium is really contracting. And this is by assessing whether there is thickening and shortening of the muscles. In the parasternal long axis view, our eyes are interested in looking at the interventricular septum and the LV posterior wall. You can see the thickening and shortening of the muscles here. You can also see thickening and shortening of the interventricular septum and the lateral wall here in the apical 4-chamber view and the subcostal view. In the short axis view, if you put your finger in the middle, you should see all the walls coming inwards, and they are coming inwards with thickening of the walls, and there is no regional hypokinesia. So you may want to take a moment here to train your eyes with what normal contractility looks like with the muscle thickening and shortening. So in patients presenting with hypotension, evaluating their cardiac contractility may guide us to whether the cause is hypovolemia if echo shows a hyperdynamic heart. Here we are going to compare normal contractility with hyperdynamic contractility. In hyperdynamic contractility, there is more thickening and shortening of the muscles and more squeezing of the left ventricle. The contraction of the walls here, you can see in the parasternal long axis view, are almost kissing. The same as in the short axis view and in the apical 4-chamber view here. Now let's compare normal contractility with the other end of the spectrum. So at the bottom of the screen here, you see generally that there is global hypokinesia. The muscles are generally thinner compared to normal. There is very poor contractility as there isn't much thickening and shortening. Okay, the next thing that we will look at that will give us a clue to the contractility is the mitral valve anterior leaflet, particularly the amount of excursion or movement it makes from the closed position to the open position. We can assess this in the parasternal long axis view and the short axis view. We are interested in the distance between the anterior leaflet and the interventricular septum when the valve is fully open. A quantitative measurement method to this is called the E-point septal separation, or EPSS. Let's briefly take a look at EPSS measurement to help us understand the visual estimation alternative to this. EPSS is measured using the M mode. It can be measured in the parasternal long axis view or the short axis view. The M mode cursor is placed through the tip of the mitral valve, and then the M mode tracing will show the movement of the anterior leaflet through the cardiac cycle. During the left ventricular diastolic phase, the anterior leaflet moves towards the interventricular septum at 2 points, E point and A point. The E point is at early diastole, when the left ventricle relaxes and rapidly fills. So here the anterior leaflet opens the widest, and then it starts to close. And then the left atrium contracts to squeeze the final amount of blood through the mitral valve, and the anterior leaflet opens again, represented by A point. For EPSS measurement, we just need the E point. It is measured as a distance from the E point to the septum. In normal contractility, the EPSS is less than 8 mm. If the EPSS is more than 18 mm, it will suggest very poor contractility. So, if we are estimating cardiac contractility by visual estimation and without making any measurements, we can use this simple rule of thumb. If the mitral valve anterior leaflet is seen touching or almost touching the septum, the EF is about 60%. If the anterior leaflet opens halfway between the closed position to the septum, the EF is about 30%. And if it opens less than halfway to the septum, then contractility is severely reduced. Now let's have a bit of a practice. So here we can see echo of 4 patients, A, B, C, D. Which of these 4 patients do you think has normal contractility? Yep, patient C has normal contractility. You can see that the anterior leaflet of the mitral valve looks like it is almost touching the septum. Additionally, the septum and the LV posterior wall seem to contract well, shown by their thickening and shortening. Patient A has severely reduced contractility. The mitral valve does not open very much. The anterior leaflet moves less than halfway of the distance from the closed position to the septum. Additionally, the muscle walls appear thinner than normal and not showing much thickening and shortening. Patient B shows some decent amount of thickening and shortening of the walls, but not as good as in patient A. If you scrutinize the proximal segment of the interventricular septum, there is hypokinesia, as it does not thicken as much as the rest of the septum. The mitral valve anterior leaflet moves about halfway the distance through the septum. I would say that patient B has mild to moderately reduced contractility. I say mild to moderate here because there is only one cardiac window. We need to assess the other cardiac windows to look for any other areas of hypokinesia before we can make a conclusion for this patient. Let's take a look at patient D. Patient D demonstrates the limitation of using mitral valve anterior leaflet excursion in our estimation. Patient D has atrial fibrillation. So when you have atrial fibrillation, there is beat-to-beat variability, making it difficult to judge the anterior leaflet excursion. So in this patient, you will have to use other approaches to estimate cardiac contractility. Another limitation of mitral valve anterior leaflet excursion is if there is mitral valve stenosis, which will restrict its opening so that you cannot apply the rule of thumb. The next visual estimation technique is to look at contraction in the axial plane, which is the plane perpendicular to the long axis of the left ventricle. Here we're looking for the change in the LV diameter from diastole to systole when the walls contract. The quantitative equivalent to this is fractional shortening. Okay, so let's briefly go through fractional shortening so that we can understand the visual estimation of axial contraction. The formula to calculate fractional shortening is the diameter of LV at end diastole minus the LV diameter at end systole. Divide this by the diameter of end diastole times 100%. You can obtain these measurements by doing M-mode, which can be performed either in the parasternal long axis view or the short axis view. The M-mode cursor is placed distal to the tip of the mitral valve. Normal contractility has a fractional shortening of 25 to 45%. If we translate this for visual estimation of axial contraction, the normal contractility will show roughly about 35% or a 1/3 change in LV diameter when it contracts, plus minus 10%. So if you look back at this example of normal contractility, focus on the change in LV diameter. Based on the normal values of fractional shortening, here the LV diameter change is about 30% or more. Here is another simple rule of thumb. In the apical 4-chamber view, you see that the most contraction is near the apical zone, followed by the middle zone. As a rule of thumb, if the LV diameter decreases by 1 centimeter at the apical and middle zones, contractility is normal. If the diameter decreases more than 1.5 centimeters at the apical and middle zones, contractility is more than 65%. And if the walls are kissing or almost kissing near the apical section, that suggests contractility of 70% or more, i.e. hyperdynamic. Now let's compare the axial contraction between normal contractility and hyperdynamic contractility. You can see that in the hyperdynamic contractility, there is a lot more squeezing of the left ventricle. You could say that the change in LV diameter is more than 50%. In fact, the apical walls are almost kissing. At the other end of the spectrum, the severely reduced contractility will show much less axial contractility. Here, the change in LV diameter seems to be probably around 10 to 15%. Okay, so the next visual estimation technique is to look for contraction in the longitudinal plane. This is the plane in the long axis of the left ventricle, as can be seen in the apical four-chamber view. When the walls contract, the left ventricle becomes shorter. Notice that the apex is actually fixed. We are interested in looking at the movement of the base of the heart, i.e. at the valvular level. Here you can see the up and down movements. There is a way to quantitatively measure this, and it is called the mitral annular plane systolic excursion, or MAPSE. Briefly, MAPSE is measured in the M mode view with the M mode cursor placed through the mitral valve annulus here. Then you get an M mode tracing of the mitral valve annulus moving up and down. MAPSE is the excursion distance between the peak and the trough. Normal contractility will have an excursion of 13 mm or more in males and 11 mm or more in females. Of course, if you are only visually estimating, we may choose not to do any measurements. So we will be relying on our eyes to try and appreciate the amount of movements that the mitral annulus is doing. Here is an example of a comparison between normal EF and hyperdynamic EF. We can eyeball the mitral valve annulus excursion in the parasternal long axis view and in the apical four-chamber view. It can be difficult to estimate here because things are moving very fast. But we have the scale at the side here, which is 1 centimeter as a guide. So here, in both cases, the mitral valve annular excursion looks similarly good. The difference then to tell whether it is normal or hyperdynamic is to look at the thickening and shortening of the muscles and the axial contraction. So here in the hyperdynamic heart, again, you see very large change in LV diameter in the axial contraction and see the walls almost kissing here. Now let's take a look at the other spectrum of EF, which is severely reduced contractility. And now it is a bit easier to perceive the reduced mitral valve annular excursion, which here is very, very poor. And this is supported by the thinner and less thickening of the muscles. So these are the 4 approaches or techniques that we can use to visually estimate cardiac contractility. Now we have not discussed the other EF categories that fall between normal and severely reduced EF. So in the next 10 slides, we will practice our visual estimation of cardiac contractility on 10 cases that include all the other EF categories. So let's try and apply the 4 visual estimation approaches in this first case here. Here you can see that in the parasternal long axis view, the interventricular septum, the LV posterior wall thicken and shorten quite well. The anterior leaflet of the mitral valve is touching the septum. In the short axis view, all the walls thicken and they together move inwards with no regional hypokinesia. The axial contraction looks good. There is at least a 30% change in LV diameter when it contracts. The mitral annular excursion also looks good, as seen in the long axis here and in the apical four-chamber view here. So this is normal contractility. Okay, so case number 2. Here we see the heart beating at a slower rate, which sometimes may give us the impression of a weaker contractility. But remember to apply the 4 visual estimation approaches and not let the heart rate distract us. So here in the parasternal long axis view, the anterior leaflet of the mitral valve is touching the septum. Overall, if you look at all the views, muscles show normal thickening and shortening. You may say that in the parasternal view here, the distal portion of the septum does not thicken as much as the rest, something like a mild hypokinesia. However, if you put everything together, axial contraction is at least 30% change in LV diameter when it contracts. Mitral annular excursion, so I put a line here and here, looks okay as well. So this is considered as normal contractility. In case number 3 here, we can see very good muscle thickening and shortening in all windows. Perhaps too good, such that the axial contraction is squeezing the left ventricle diameter to almost kissing. So this is hyperdynamic contractility. Okay, case number 4, you can see that there is globally poor thickening of the myocardial muscles seen in all windows. The mitral valve anterior leaflet opens less than halfway, the distance towards the septum. Axial contraction is minimal, probably about 10 to 15%. Longitudinal contraction as seen at the mitral annular plane is also very poor. So this is severely reduced contractility. Case number 5 here, you can say that the contractility does not really look normal. By now, your eyes would have been so familiar with what normal muscle thickening looks like in the interventricular septum here and in the septum here in the apical 4-chamber view. But at the same time, this also does not look like severely reduced EF. So you have between mildly reduced and moderately reduced contractility. Judging by the axial contraction, I think it's less than 30%. And then the mitral valve anterior leaflet that goes about halfway the distance to the septum. And then let's take a look at the mitral annular excursion, which is reduced. I would say that this is moderately reduced contractility. Case number 6 here, you can see that the myocardial muscles are hypertrophic. But these already thick muscles are not showing that much of thickening and shortening during systole. The mitral valve anterior leaflet opens much less than halfway the distance towards the septum. Axial and longitudinal LV diameters also show very minimal change during contraction. Let's take a look at the mitral annulus excursion. Yeah, it's very poor. So this is severely reduced contractility. Case number 7. Okay, so if you look at the mitral valve anterior leaflet, it moves a little less than halfway towards the septum, something that you see in severely reduced EF. If you look at mitral annular excursion, it is also reduced. However, muscle thickening and shortening is a bit better than what you would expect to see in severely reduced EF. Probably a bit less in the apical, but yeah, it's a decent amount of thickening and shortening in the long axis and the short axis. I would say the axial contraction in the short axis view is about 25% change in the LV diameter. This is considered as moderately reduced contractility. Okay, case number 8. Okay, so again, this is just to make our eyes more and more used to differentiate normal from hyperdynamic contractility. We have very good thickening and shortening in all windows. And in all windows, you can see that the apical segment is almost kissing. So this is hyperdynamic contractility. Case number 9. In the parasternal long axis view, we can see good thickening of the interventricular septum as well as the LV posterior wall. Mitral valve anterior leaflet is almost touching the septum. We see a similarly good amount of muscle thickening in the short axis view and the apical 4-chamber views. However, the mitral annular excursion is reduced compared to normal. In the short axis view here, there is regional hypokinesia at the posterior wall. So this part of the wall is not coming inwards to contribute to the full axial contraction. So after considering the normal thickening of muscles, the anterior leaflet of the mitral valve that is touching the septum, and the normal axial contraction, however, with reduced mitral annular excursion and the posterior wall hypokinesia, this is considered as mildly reduced contractility. Okay, this last case is a bit tricky. First thing is the heart rhythm is irregular. This patient has atrial fibrillation, making EF estimation difficult. Muscle contraction seems hyperkinetic. Axial contraction looks good. However, there are a few subtle things here. Firstly, the mitral annular excursion is slightly reduced, as can be seen especially in the apical 4-chamber view here. If you look carefully at the short axis view, there is a fibrillating period where the change in LV diameter is not by much. So this can be considered as mildly reduced contractility. The mildly reduced and moderately reduced EF are probably the challenging ones to recognize. The take-home message is to train your eyes with lots of normal contractility and train your eyes to recognize the two ends of the EF spectrum. When you become more expert in those, it makes it easier to rule out normal, hyperdynamic, and the severely reduced EF when you see something that does not fall into any of these three categories. Use all the 4 visual estimation approaches. Don't make your conclusion before you have viewed all cardiac windows, because the EF estimation is made after you sum up and subtract the findings from all windows put together. And finally, do correlate your findings clinically.